Module 2, Headaches, Visual Function, and Visual Disorders. This is a reminder of your required reading for both your Davis textbook and your ATI textbook. We will be starting with Chapter 36 from your Davis textbook on headaches. Okay, so we're going to start off with cephalalgia. Cephalalgia is the medical term for headache. So why do we get headaches? So we have these pain receptors, these nociceptors, that are triggered. Once these pain receptors are triggered, they send a message to the brain, the thalamus specifically, via the trigeminal nerve, which is cranial nerve 5, and that results in us feeling a headache. So headaches are categorized into two groups, primary headaches and secondary headaches. Primary headaches are not caused or associated with any other underlying disease, while secondary headaches are associated with some type of structural problem or obstruction like stroke, tumor, meningitis, or encephalitis. So now we're just going to talk a little bit about each subtype of primary headaches. So first we have tension headaches, which are considered to be muscular. So these headaches may be episodic or chronic, and that is determined by how frequent the headaches come and how long they stay. So some signs and symptoms of tension headaches would be mild to moderate pain that is typically bilateral in the occipital area. The occipital area is towards the back of the head. So patients often describe the pain as constant pressure to the face, head, and neck, and often complain of sensitivity to light as well. Then we have cluster headaches, which are considered neurovascular, so neurological. And these typically present with severe, unrelenting, unilateral pain in and around the eye. Okay, so think cluster headache, unilateral around the eye. Usually peak pain is usually within about 5 to 10 minutes after onset, and it can continue in intensity for about 1 to 3 hours. They generally occur around the same time for several weeks and more commonly at night, and reoccur daily to near daily for weeks to months, followed by periods of remission. Next are migraines. So migraines are a little more complex, and they are isolated into 4 phases. We're not going to go into too much detail with migraine. So the premonitory phase, which is about 24 hours before the migraine headache develops, patients can experience signs and symptoms like mood changes, fluid retention, increased urine output, excessive and uncontrolled yawning, and food cravings. Right before the migraine, some patients will experience an aura. So an aura can be flashing lights, it can be muscle weakness, it can be a certain smell, a certain taste. Every patient may have their own aura or no aura at all. After that, we consider the headache phase, where the pain will start gradually and will slowly build in intensity. So for some, they may not have the pain. There's a migraine without the headache pain. And then following the headache, we have our postdromal phase, and at that time patients can be confused and exhausted. And this period can last as long as 24 hours before the patient feels like they're back to their baseline. So there are medications to treat migraines, and this is individualized. So some medications may work for some, while others it doesn't work as well. So these medications will be on a trial basis to see what works for the patient. As far as diagnosing this, we want to get a good history and physical, and because the trigeminal nerve is what's sending the message to the brain for most headaches, we want to make sure we do a neural exam. We want to also rule out infection, because that can also lead to similar signs and symptoms. So we're going to be checking blood work. We want to palpate the head, because if there is some type of injury to the head on the outside, you want to make sure you know about it. And we also want to do labs. So we're going to do a CBC, a complete blood cell count, which can show if the patient's anemic or may have an infection. We want to check the electrolytes because the patient may be dehydrated, or that may also show other types of electrolyte imbalances that may be indicative of a different type of condition. We also want to do a UA, a urine analysis. That can also show infection and other diagnoses such as diabetes. And then we want to do other diagnostic studies like imaging such as CT, MRI, EMG, EEG, to see if there's any evidence of any other type of disease. So remember, we're talking about our brain and our head. Our brain is our most vital organ, so we really want to rule out all of the things that can lead to a severe complication. We want to encourage our patients to make a headache diary and provide a detailed medical history so that we can see if there are any patterns. Once there is a diagnosis made, then treatment can get started. So oftentimes, also as a side note, depression and anxiety can also cause tension headaches. So patients may benefit from counseling and anti-anxiety and antidepressant medications. So again, very individualized, kind of trial and error with maybe anti-inflammatory meds, stuff like that. So also, you'll be studying this in your pharmacology class. So again, I'm not going to go into too much detail with medications, but for drugs. So for tension headaches, most commonly used is aspirin, acetaminophen, or NSAIDs, or a combination of them. Also, it can be something that could help sometimes is caffeine, a sedative, or muscle relaxant. For cluster headaches, drugs of choice would be triptans. Those are the standard treatment for occasional cluster headaches. Oxygen, 100% O2 by non-rebreather mask, can also help with tension headaches. And high-dose verapamil is actually one of the first choice drugs also. And for migraines, so the goal of treating migraines is to stop the migraine once it's started, to stop it, or to decrease the symptoms. So NSAIDs, aspirin, caffeine-containing analgesics, or triptans can help to decrease that neurogenic inflammation of the blood vessels in the brain and cause vasoconstriction, which in turn will help with migraines, or at least that's the idea. There are many people who suffer from migraines who don't get relief. So despite all of these measures and medication, they're still, experiencing really painful migraines. And also, there's something called medication overuse headaches, where some people will develop chronic daily headaches as a result of excessive use of over-the-counter medications like Tylenol and ibuprofen. So that is also something you want to keep in mind. So medication overuse would be considered a complication of headache. And then another complication would be status migrainosus. That's when you have a continuous migraine that just doesn't stop. So those patients would need to be admitted into the hospital. So we have a patient who is 33 years old, female, complaining of headaches at her annual health exam to her provider. What questions will you ask this patient as part of your assessment? So there are so many factors that contribute to the source of a headache or could potentially be a cause of a headache. So we really have to get a really good history and physical on the patient. So if you look at the slide, there's many things that we need to ask about. So when did it start? When did it end? Did you have an aura? And what was the aura? Where do you feel the headache? Is it behind the eyes, back of the neck, temporal, both sides, one side? Describe the pain. Description: throbbing, pressure, piercing, stabbing. Rate the pain on a scale from 1 to 10. Do you have any other symptoms that come along with the headache? Did you take any medication? What did you try at home to make things better? Are you taking medication, or did you do like an ice pack, dark room, etc.? And did that treatment work? How do you sleep at night? How many hours? Did you eat something before the headache started that could have triggered it? Because we know that some artificial sweeteners can actually cause headaches or migraines. Aged cheese, chocolate, ice cream, salty foods, nuts, certain foods that have a lot of preservatives like bacon, hot dogs, processed foods. So all of these things could be triggers. It's really important to find out what the trigger is so the patient can avoid those items. Sometimes if you skip a meal, that can trigger that, a stressful event, weather changes, and menstruation, or if the patient is on birth control pills. So many questions we need to find out, but the better history we can get, the better that we can treat these patients. So nursing management, we went over the signs and symptoms. Again, it depends on the type of headache is what we're going to see. Most common complaints, generally speaking, is going to be acute head pain, sensitivity to light, nausea, vertigo, and an aura. So those are all very, very common with any type of headache, not just one specific one. We're going to take vital signs because we want to rule out an infection. That could mean like a high heart rate, high respiration rate. We also want to check the circulation, so our blood pressure. So vital signs are really important also. And sometimes if they're in a lot of pain, that will change the vital signs. We want to know what the triggers are. We talked about that, and we want to know what the abortive and preventative measures are. What that means is what stops the migraine, what helps the migraine, and what do you do to prevent it. So those are our goal. And then the auras, do they have an aura? What is it? We're going to give medications. We're going to teach the patient to stay in a low stimulus environment, quiet, dark, calm. We want to teach the importance of adequate sleep. Sleep and rest are actually associated with a decrease in headaches associated with stress. We want to also teach them to take pain medications as prescribed. Severity of headaches may be better controlled with timely and appropriate medication regimen. So they should anticipate the pain. They shouldn't wait too long before taking their next dose if they're already in pain. And food triggers. We want to identify the food that is triggering these things and eliminate them from their diet. And then evaluating care outcomes. We want the headaches. So we know that headaches can become chronic and debilitating, meaning it can affect their ADLs, their activities of daily life, their work, their social life, their sleep. So it's important that we come to an appropriate diagnosis and a management plan for them. Next, we're on to visual function. So visual function, so how do we see? So vision is one of the most sophisticated systems in the human body. And if you see here, light enters the eye, there's electrical signals, and then the brain picks them up for processing. Here you can see the internal and external structures of the eye. On the left, you can see there are many, many, many little tiny structures of the eye all working together to help us see. And then we have on the right side the external structure. So that's everything that we can see just by looking at somebody with our eyes. So here are the cranial nerves that are involved in eye function. We have cranial nerve 2 optic, 3 ocular motor, 4 the trochlear, and 6 the abducens. So you are all familiar with the cranial nerves, so just make sure you know that these 4 are involved with vision and eye function. Next is the visual pathway. So you can see here we are coming through the eyes. So light passes through the cornea in our eye, through the aqueous humor, through our lens, through vitreous humor to our retina, which there is connected to the optic nerve, to the optic chiasm, and finally to occipital cortex in the brain, where our brain will make sense of everything that we are looking at. Okay, inside the eye we have our retina, which is an extension of the optic nerve. The optic nerve is also known as cranial nerve 2. So on the retina there are rods and cones. So rods are responsible for vision at low light, and cones are responsible for our color vision. So very important structures in our eye. Okay, these are some terms that you should be familiar with. Here is a picture of some of those terms, and we'll talk about each of these coming up. Next is the assessment of the visual system. So in order to determine whether the patient is having something abnormal, we need to know what is normal and we need to gather our data. This is our assessment part. So this is going to include a good personal history. That includes what kind of medications they're taking, what is their occupation, their family history. Does their family have any type of cancer or other conditions that may be related to the eyes? Nutritional history, history of eye trauma or procedures. All of those things can give you clues to what their current eye condition is. We're going to inspect the eyes, so all of those external structures that we can see, including eyebrows, eyelashes, all of those things. Then we have to recognize the cues on what is not normal. So let's talk about what is normal. So starting with visual acuity, so how well they see. 20/20 is normal. Patients should not have double vision, no drainage, the conjunctiva should be clear, the lens should be clear, sclera should be white, patients should have perla, and extraocular movements should be intact. And how do we test vision to determine their visual acuity? One way is the Snellen chart. This is where you have all the letters. On a chart, you stand 20 feet away, they read whichever line is most clearest to them, and then they get a score. We check each eye individually and then both eyes at the same time. If they wear contact lenses or glasses, they should put those on for the test. Then we have the Ishihara chart. This is to check for color blindness. This is most common in males, but some females are also colorblind. And then we have the Rosenbaum Pocket Vision Screener or Jaeger card. So this is a card that you hold 14 inches away. This is most commonly used in the elderly, but anybody can use this. And this is testing for farsightedness. So if they're not able to see it's very similar to the Snellen chart. It's just you're holding it 14 inches away from the face. So if you can't see those lines at 14 inches, then you would have farsightedness, so you can't see objects up close. Okay, this is a picture of the 6 cardinal positions of gaze. This is testing for or assessing the extraocular muscle function of cranial nerves 3, 4, and 6. Then we have our different diagnostic studies. This includes CT scan, MRI, ultrasound, and nuclear medicine testing. So CT scans can be used to diagnose diseases in the eye that are in blood vessels or related to the eye muscles, optic nerve. They can see abscesses, which are pockets of purulent exudate in or around the eye. They can see fractures in the socket. It can see foreign bodies, and this can be ordered with or without contrast. So when we say with contrast, that means the patient is going to get an injection intravenously of a dye that will show up on the imaging. The dye is iodine, so if you have an order for a CT scan with contrast, then you need to make sure that the patient does not have an allergy to iodine. Next is an MRI, magnetic resonance imaging. So MRIs give detailed views of the soft tissue with no bone or air contrast. And this is used to look for tumors, infection, chronic diseases, fractures, changes in the optic nerve, or enlarged eye muscles. Ultrasound is done by using a high-frequency sound wave to produce images of soft tissue. And they use this when it's difficult, when there's some other type of condition where it's difficult for the provider to see in the eye. Sometimes they use this approach with an ultrasound. They can see cataracts and retinal detachment using an ultrasound. And this can be done in the doctor's office, so it's convenient. Then we have radioisotope scanning. So this is done in the nuclear medicine department, and the patient is injected with a little bit of a radioactive substance, and this is going to light up the whole head. This is the picture in the bottom right. So this is done to identify tumors and ocular melanomas, cancer. That's sometimes hard to see with other diagnostic studies. Continuing with our diagnostic studies, we have slit lamp testing examination. This is this picture here on the top right. So this is a very common machine that's used. You kind of place your head in that contraption there, and the provider is able to shine a light and can see almost everything inside your eye. Then we have our intraocular pressure testing or tonometry. So this is this bottom right. There are a couple ways to do this. This one, you can see that little probe in front of the eye is going to push air in, and that is testing the intraocular pressure. Then we have corneal staining test, which is this blue one. This is when there's this, actually it's a yellow-orange dye that is in eye drops, and it's placed on the eye. And then when you shine the light, it will show any like abrasion easier than just looking at it. Then we have the fluorescent angiography. So this is when the patient is injected with a dye, again iodine, so we have to make sure that the patient's not allergic. It's injected and it's going to light up all of the vessels in the eye. So this bottom left picture, and that will show if there's any type of vessel changes that might be related to circulation. Could be like diabetic retinopathy or some type of retinal hemorrhage, macular degeneration, or even a tumor. Health promotion. So preserving our eyesight is very important. Even losing sight out of just one eye can be life-changing, so we want to make sure that we protect our vision. So we want patients, if they're going to be working around anything that can damage or hurt their eye, they should be using protective goggles. That goes for occupations or at home doing DIY projects. We want to protect our eyes from the sun because you can get cancer in your eye. So sunglasses. And we want to make sure that people are getting their routine eye exams so that if there is something wrong, then it can be caught early and treated before the patient develops any type of, complication. And patients that have chronic diseases like hypertension and diabetes, they're advised to keep their diseases well controlled so that they don't have other complications in their eyes related to those diseases. Okay, so now that we know what is normal and abnormal and all of the tools and exams that we use to assess visual function, now we're going to talk about visual disorders, starting with refractive errors. So before we talk about what a refractive error is, let's talk about what refraction is. So refraction is the eye's ability to bend light rays so they fall on the retina. This creates a sharp image. So as the light shines into our eyes, our eye then will pinpoint it to where it's supposed to fall on the retina, and that's how we can see clearly. So with refractive error, something is wrong. That light isn't being projected to the retina as it should be. So usually it's three main reasons why this happens. It can be one, the cornea is not shaped correctly. There's like a strange curve. The focusing power of the lens itself. So we have these little ciliary muscles that are on the sides of our lens, and sometimes they don't manipulate it as they should. So the lens isn't bending the light rays as it should. Or it could be length of the eye. So maybe your eye is short or long. Either way, it's going to produce a refractive error. This is the most common visual problem. So before we get started, I forgot to mention that these eye problems you're not going to really see in the acute care setting as the reason why they came in. This is going to be most likely something you see in their history, or maybe they'll be coming to the doctor's office or possibly maybe a clinic with these issues. So signs and symptoms of refractive errors is going to be dependent on the type. So we have myopia, hyperopia, astigmatism, and presbyopia. So myopia is blurred vision for distant objects. So that means you can see up close clearly. Myopia, myself, so you can see myself in the mirror up close. That would mean you are nearsighted. You can only see near. Then we have hyperopia, which is the opposite. So you have blurry vision of objects that are close by, but you can see distant objects clear, so you're farsighted. Then we have astigmatism. So astigmatism is when objects that are near and distant are blurry. It causes you to squint and have headaches. Also, you get glare at night, like the lights kind of have like a flare. Then we have presbyopia. Presby prefix means age-related, so this is presbyopia. inability to focus on objects held close to the face, so they're not able to see up close. And this is an expected change around midlife. So around the age of 40-45, many patients will experience presbyopia. So there are surgical and non-surgical ways to manage refractive errors. Non-surgical ways would be glasses, depending on what type of error you have. You can have bifocal, trifocal, or you can use contact lenses. We want to teach the patients to use good hand hygiene, good eye hygiene, wash your hands, and to monitor for complications because we are inserting a foreign object into our eye that is prone to collect bacteria. Then we have orthokeratology. So this is a special contact lens that is a non-surgical option to reshape the cornea. So the patient wears a special contact lens that slowly will reshape that cornea, and it can correct myopia over time. There are several surgical options to treat refractive errors. The most common one that you may have heard of is LASIK, L-A-S-I-K, and this is a video here. Okay, so this video, it appears to be very invasive, but this is actually considered minimally invasive surgery. It is considered to be low risk and safe for most patients, and most patients will report improved vision before they leave the office. So your responsibility for procedures like this is teaching for the patient. So once they go home, they should be on the lookout for signs and symptoms of infection. That would be increased pain, maybe drainage, bloody drainage, sanguinous, or purulent drainage, and they should report that immediately to the doctor. We want to instruct them to take the medications if prescribed at home and to refrain from activities that will cause intraocular pressure to be increased, such as coughing, sneezing, bearing down, picking up heavy objects, those types of things. All right, so just to recap here, so if you have a refractive error, then treatment is going to be based on the patient expectations. Maybe they want surgery, maybe they want glasses. If they're older, in their 80s, they may not want to do LASIK surgery. Interventions, we're going to do a lot of teaching, make sure that they're wearing their glasses correctly and that they have adequate lighting because light is important to see. We're going to take their vital signs, we're going to monitor their eye changes and make sure we get a baseline visual acuity for them. And teaching, again, protect the eye, wearing protective goggles, report changes, And again, all of those post-operative instructions. Next is vision loss related to opioid use. Vision loss related to opioid use. So how does this happen? The word for this is endogenous endophthalmitis. So endogenous means it's coming from inside of the body. So this infection can be bacterial, fungal, or viral. This patient has a blood infection, and the way we know this is because blood cultures were performed, meaning we drew blood, we cultured it, we waited, and then something grew, whether it was bacterial, fungal, or viral. It doesn't matter what the cause is, we still say endogenous endophthalmitis. So that infected blood travels to the eye where it settles there, and then it has an infection. So here in the US, the cases of this have dramatically increased since year 2000, and it is directly related to IV opioid drug use. So these people may have used a dirty needle, contaminated non-sterile needle, and the microbe, was transmitted into the bloodstream and made its way to the eye. All right, so clinical manifestations are going to be red, painful eye, photosensitivities, floaters, and reduced vision. Something you'll see when you look at the patient will be a white infiltrate on inspection. So I'm going to circle that here for you. White infiltrate. The way we're going to assess these patients, we're going to look at their vital signs, take their vital signs. They might have a slight elevated in temperature that can be due to infection or inflammation, and they can have elevation in heart rate and blood pressure that may be related to anxiety or recent IV drug use. Visual changes, that infectious process can cause visual changes, and the patient is going to report this, the presence of floaters and just not being able to see that well. The eye appearance, we just described that, what those signs and symptoms are: painful, redness, tearing, edema. Diagnostic results from our visual acuity changes, we're going to see that white infiltrate. And what are we going to do about it? So treatment for this, we're going to administer medications, whether it's antibiotics, antifungals, or antiviral, depending on what the organism is. And this can be injections into the eye itself and or IV medications, just depends on the patient. So we're going to provide comfort care, supportive care. This is going to include cool compresses applied to the affected eye that will help decrease inflammation, and it's also soothing. And they should be instructed to wear, dark sunglasses for that photophobia when they're in bright light. For teaching, anytime we have any eye-related vision changes, safety is going to be a big concern. And we want to make sure they don't fall or have other injuries, whether it's at the hospital or at home. Activity level should be based on what the doctor says and any diagnostic findings. So they may not have any activity restrictions. Of course, we're going to teach hand hygiene so that, this isn't transferred to one eye to another, because it's possible they only have it in one eye. Medications, really important that they follow the treatment, and they should not stop midway once the eye is, feeling better. And then we want to educate on the relationship between the IV opioid use and the development of this type of infection, and offer support and resources for them regarding the drug abuse. Make sure that they follow up with their provider, and we want to prevent this from happening in the future. Next is conjunctivitis. So conjunctivitis is an umbrella term. It's used to describe inflammation or infection of the conjunctiva of the eye. There are several types of conjunctivitis. Just remember that that's an umbrella term, just means infection or inflammation of the conjunctiva. So they can be viral, bacterial, it can be related to allergies, it can, all kinds of things. So most commonly we have allergic conjunctivitis, and that is when there is some type of trigger in the environment, like pollen or dander. And signs and symptoms would include a red-pink sclera, intense itching, burning, tearing, and puffy eyelids. Allergic conjunctivitis is usually both eyes. Bacterial conjunctivitis is an infection caused by bacteria, and it usually feels like you have sand in your eye when you blink, like you have something scratchy in there. It is often accompanied by purulent eye discharge and matting of the eyelashes, and patients will say when they wake up in the morning, the eye is kind of glued shut. Viral conjunctivitis is from a virus, and it's most oftenly seen with a cold, a virus affecting the upper respiratory tract, sore throat, and this will present as watery discharge, and this one is usually one eye, but it quickly spreads to the other eye. Then we have chlamydial conjunctivitis. This is a sexually transmitted infection via hand to eye from infected genital secretions. And just a side note, this can also be spread or transmitted during birth from infected mother to newborn. So we want to rule out all STIs before a mother gives birth. So those are just some of the types of conjunctivitis. There's several more that you can read in your textbook. So many of the signs and symptoms are similar to each other. So it's important that you get a good history on the patient to make the correct diagnosis. For example, tearing, itching, and inflammation are observed in all of them. So that's not enough to make a diagnosis. Our assessment, we're going to include vital signs. Body temperature can be indicative of elevated body temperature, could mean infection or inflammation. The appearance of the eye, we're going to look at it for those signs and symptoms. Diagnostics, so most of this diagnosis is going to be based on the physical examination and history. It is possible that the doctor will want to take a culture of that purulent drainage, but usually that's not necessary, but it is an option. Age-related considerations, this affects everybody of all ages, so no age group is more at risk than another. Pharmacological therapy is going to include drops, whether they're just depending on what the eye problem is. It can be the antibiotics, antiviral. It can be just plain, normal saline. We want to provide comfort care. So this includes cool compresses that will soothe the eye and help decrease inflammation. We want to give sunglasses or teach the patient to wear sunglasses just in case they have that photosensitivity. They can give those eye drops, so we want to make sure they know how to give them. And if there are difficult to treat signs and symptoms, then we can refer them to an eye specialist. We always want to teach hand hygiene so that they don't spread it to their other eye or to another person around them. Bacterial conjunctivitis is very, very, very contagious. So at home, we want to tell them, not to share towels. They shouldn't be sharing the same pillow with someone, and they should be washing their hands frequently. They should complete all of the prescribed medications, especially antibiotics, because an infection can actually progress deeper into the eye. So it can start on the conjunctiva, but can actually go deeper in the eye. So we want to make sure that they complete their meds. Next, we have corneal abrasion. We're not going to go over this slide in depth. I just want to let you know that this does exist. So this is just what it sounds like. You have an abrasion on your cornea. It can be as a result from trauma, maybe a foreign body, your contact lenses, or just a spontaneous defect. It can range from really, really superficial, or it can be, really deep in the eye. And this is going to be treated based on severity. So if it's just superficial, then not much you need to do. It'll heal on its own with 1 to 2 days. Signs and symptoms are going to be eye pain, redness, tearing, squinting, photosensitivity, sensation of a foreign body in the eye. So maybe you feel like you have sand or scratchy. We're going to give some medications depending on the severity, and then we're going to teach the patient. Usually they're given an eye patch to wear with the meds. We're going to teach them how to take it and to report any signs and symptoms of worsening vision or infection. You can read more about this in your textbook if you'd like. Next is cataracts. So you can see in this picture here, there's a very large grayish circle here, that is a cataract. And this is a result of increased proteins in the lens of the eye that will ultimately impair our vision. So if our lens is not clear, then we're going to have blurry vision because that light isn't directed appropriately onto our retina. All right, so cataracts. So there are millions of people in this country that have cataracts. And by the age of 80, more than half of all people in the US will have had a cataract. So very common. So there are a lot of risk factors. We have exposure to UV light. So if you work outside a lot or you are at the beach a lot, something like that, it puts you at higher risk, especially if you had started that activity at a younger age. Advanced age, just you hitting the age of 60 will put you at risk of getting a cataract, but you can get a cataract at any age. Family history, cataracts tend to run in families, so we want to make sure we ask that question. Race and ethnicity, African Americans and Hispanics have much more higher risk of cataracts than Caucasians. So again, you want to make a note of that when you are assessing your patient. And any type of medical condition, chronic medical condition, can also contribute to the formation of cataracts, especially if it's something that affects circulation in the body, like diabetes, hypertension, smoking, and other environmental factors. Okay, so we're going to move on to how this is diagnosed. So for any eye problem, whether it's eye pain or a patient that has a change in vision, we're going to do a visual acuity test. And these patients, the provider will look into the eye with an ophthalmoscope and a slit lamp to see the eye up close, and usually they can see the cataract easily. If not, then they can do an ultrasound. So the best option for this, the go-to, is to remove the cataract via surgery. The reason for this is that cataracts are progressive and it will just keep getting worse and eventually could leave the patient blind in that eye. So if for some reason the patient is not able to have the surgery or they refuse to have the surgery, again, it's up to the patient, they need to know that this is progressive and that they need to make sure that they get their routine eye exam so that their prescription can be changed so that they can see as long as they can effectively. And for any vision impairment, we want to make sure we educate them on safety measures. So, for example, driving and other activities that require eyesight, they need to be evaluated to make sure that they're still able to see well enough to do those activities. When it comes to their eye drops, their eye medication, mydriatic drops, which are drops that dilate the eyes, and then cycloplegic drugs or drops paralyze those ciliary muscles to keep the eye dilated, are often prescribed before surgery and in preparation of surgery. So we want to make sure the patient is aware of that. Whenever you have any type of eye drop that's going to dilate the eyes, the eye is going to allow lots of light in. So we need to make sure that they wear dark glasses if they go outside. For after the procedure, the patient should lay on their back or non-operative side. So this will promote drainage and it will decrease the intraocular pressure. So again, after procedure, after cataract, the patient should be on their back or on the non-affected side. Sometimes the doctor will order an eye patch. So if they did, we want to let them know that will protect the eye and it minimizes the eye movement, which will decrease discomfort. We want them, again, to refrain from activities that increase intraocular eye pressure. So they may need a stool softener. They should be advised to increase their fiber and fluid intake. They shouldn't strain with bowel movements when possible. So we want to make sure that they're following their preoperative orders, including being NPO, nothing by mouth before, making sure they have their preoperative eye drops, making sure there's a family member to come pick them up after procedure, stuff like that. And we want to also educate the family members when they go home. And with the eye drops, we want to make sure that they're able to administer them or have a family member help with that. So if a patient has a cataract, they can leave a normal life. Once that lens is removed surgically, they get an implant and they're going to be able to see pretty good after that. One thing to know is that after cataract surgery, they should have minimal to no pain. So if they're complaining of eye pain increasing, that is a red flag. They should come in to see the provider. And these images show what it would be like if you had cataracts, what it would look like. Next is glaucoma. So glaucoma is a group of disorders characterized by increased intraocular pressure. And because of this intraocular pressure, the optic nerve becomes impaired and it atrophies. So those little nerve cells begin to die. This is going to result in peripheral vision loss. Okay, so remember, glaucoma, peripheral vision loss. So anyone can develop glaucoma, and it is the leading cause of blindness in the world. So very common, and our ultimate complication is blindness, and that's what we're trying to avoid. So there are several types of glaucoma. We have primary open angle glaucoma, angle closure glaucoma, normal tension glaucoma, secondary glaucoma, pediatric glaucoma. So lots of glaucomas. We're going to focus on the most common, which is going to be primary open angle, and then we're going to talk about the most severe complication, which would be the acute angle closure glaucoma. Okay, so this first picture here, you see a normal eye, and let me show you. So here we have drainage canals, which drain the aqueous fluid from our eye as needed. So we produce aqueous fluid, and then our eye automatically will drain to keep a balance within the eye. With glaucoma, these little drainage canals here are either narrowed or they become blocked completely. So the aqueous fluid in the eye begins to build up. That buildup pushes on the optic nerve, which will cause irreversible damage to the eye. Okay, we're going to start with risk factors for glaucoma. So family history. So this does run in family. If you're over the age of 60, if you have some comorbidities such as diabetes, hypothyroidism, if you have myopia, that will put you at high risk for glaucoma, and if you have prolonged use of corticosteroids. So signs and symptoms. So primary open angle glaucoma, which is the most common, you're going to have painless, gradual loss of peripheral vision. So this center picture here, you see our peripheral is on the outside of the circle. So you start having loss of peripheral vision, and it's usually going to be both eyes. It's not that common to have glaucoma in only one eye. It is possible, but not that common. And as the disease progresses, you will eventually have tunnel vision, meaning you'll only be able to see centrally like this. Okay, so remember, primary open angle glaucoma is going to be gradual loss of peripheral vision. Okay, no pain involved, and it's usually going to be both eyes. Then we have acute angle closure glaucoma. So with this one, it means that those little ducts that are draining the fluid are completely shut. So that fluid is building up in the eye. This is going to be abrupt, severe eye pain. Patient can have nausea, vomiting, visual disturbances, especially at night with glares, blurred vision and reddening of the eye. Okay, so those are the two that you should remember. This table is from your textbook. These are different eye drops used for the treatment of glaucoma. So because we're dealing with fluid, there's a lot of cardiac medications that you see here in eye drop form. So typically patients who have glaucoma are prescribed sometimes 5, 6, 7 different types of eye drops. So if you look here, for example, beta blocker medication, the older patients get, the more conditions they're going to have. So they could possibly be on a beta blocker for something else unrelated to the eyes. So this becomes crucial that these patients have teaching that when they're administering these eye drops at home, that they are putting pressure on the nasolacrimal duct for at least 30 to 60 seconds. So that will decrease systemic absorption. Okay, so really important education. Sometimes these are contraindicated with patients that are taking similar medication drug classes. So any patient being prescribed glaucoma medications, you should ask, what kind of medications are you taking at home, and make sure none are contraindicated. For patients who are not successful with management with the drops, then they will need surgery. Acute angle closure will definitely need surgery. Primary angle closure will have surgery only in severe cases, and you can read about these more in your textbook. Okay, for glaucoma, our assessment is going to include a physical assessment using that ophthalmoscope and a tonometer so we can check the intraocular pressure of the eye. Remember that normal intraocular pressure is 10 to 21. Diagnostic results are going to include that IOP measurement and also a visual acuity test. So we're going to use that Snellen chart to assess, how the decrease in visual acuity. Then we have age-related considerations. So proper screening and routine visual exams of patients at advanced age will help detect this early, hopefully, and then, it can be treated before it gets worse, because this again causes irreversible damage. All of that pressure on the optic nerve will cause those cells to die. Intervention, so administer medications. Again, there's eye drops. We need to educate on how to give them, and these are going to either decrease the production of or increase the outflow of that aqueous fluid. We want to make sure they follow the procedure when giving those drops. Maintaining aseptic technique is really important so they don't end up with an eye infection. We want to make sure to elevate the head of the bed 35 to 40 degrees because that promotes intraocular drainage and decreases intraocular pressure. They want, or they shouldn't do all those activities again that increase intraocular pressure, like bending at the waist or coughing, sneezing, picking up heavy objects for at least 48 hours post-op if they have one of those surgeries. And they may need a stool softener and all of those other instructions so that they don't strain. These patients need education about the progressive nature of the disease and that you cannot cure glaucoma, so all of those drops they take have to be taken for life, and if they stop taking them, glaucoma will return. So really important education. Macular degeneration. So before we talk about degeneration, we need to know what the macula is. So you can see it here in this picture right here. It is a part of the retina at the back of the eye. It's about 5 millimeters across, and it is responsible for central vision, most of our color vision, and fine detail. So if you have a problem with your macula, your vision may look like this one here. Okay, so central vision is affected. All right, so modifiable risk factors: high blood pressure, high cholesterol, obesity, smoking, and not enough zinc in your diet. Non-modifiable, just being over the age of 60 puts you at risk of macular degeneration. If you have history in your family, women are more likely than men, and Caucasians are higher risk for getting macular degeneration. Pathophys. So dry macular degeneration is the most common form of macular degeneration, and this is when the light sensitive cells in the macula slowly start to break down. So this form can actually turn into the wet form, the wet macular degeneration, which is more severe. So all people who have wet macular degeneration initially had dry macular degeneration. So one of the most common early signs of dry macular degeneration is drusen bodies. And you can see that down here next to this light bulb, drusen bodies. And these are yellow deposits that are located under the retina and are usually found in the eye of people over the age of 60. So these can be seen with comprehensive eye dilation. So they'll give the drops to dilate the eyes, and then they'll take a look inside and they can see these drusen bodies. So when you see these drusen bodies, They usually mean macular degeneration. So wet macular degeneration happens when abnormal vessels that are located behind the retina start to grow under the macula. So these blood vessels are very fragile and they tend to leak blood and fluid. So the blood and fluid raise the macula from its usual spot in the back of the eye, and that damage from this process happens really fast. So the signs and symptoms of macular degeneration include straight lines that appear distorted, absent or distorted central vision, dark blurry areas or whiteout on center vision, and diminished or changed color perception. But mainly it will be described as loss of central vision. Okay, so for diagnosing macular degeneration, again, comprehensive eye examination that includes pupil dilation so they can take a look inside that eye. The three most common procedures or treatments for macular degeneration are laser surgery, photodynamic therapy, and injections directly into the eye. One thing to note is that there is no cure for macular degeneration, and even if the patient gets all of the treatment, it still may progress and the patients may still experience vision loss. So that's something that you want to, let the patient know. And that means that the patient needs to be followed up. So they should continue to see their provider routinely. One of the tests that are done on patients is using this Amsler grid pictured here. So the patient is given a cardstock of this grid here and then another cardstock where they need to draw it, what they see. And then they'll draw these distorted lines, which is a sign that the macula has been affected. Retinal detachment. So retinal detachment is when there's separation of the inner layers of the retina from the underlying retinal pigment epithelium, also known as a choroid. So if you see in this picture, there's a small tear in the retina, and then fluid from inside of the eye goes through it, and then it pushes that retina away from the back of the eye. Risk factors for retinal detachment include extreme myopic refraction disturbances. So if there is extreme myopia, then this may lead to retinal detachment. If the patient has history of retinal detachment in the other eye or family history, cataract surgery, eye surgeries, and any other eye disease or disorders, and some systemic diseases like diabetes, sickle cell disease, leukemia, things that may interrupt circulation also, can end up with some type of tear in the retina and then have this retinal detachment. So the signs and symptoms that patients will manifest with are floaters in the visual field. So in this picture, these little black specks are floaters. Light flashes are also common, and then the appearance of a curtain over field of vision. So this is like this black curtain-like disturbance. Treatment for this is usually surgical, so laser photocoagulation is the most often used procedure to repair a retinal tear or hole. It's usually done as an outpatient, so the patient does not need to be admitted to the hospital. It doesn't require incisions also. So the way they do this is the surgeon will direct a laser beam to burn a small pinpoint hole on the peripheral retinal surface. So this burn will create a scar that will have scar tissue that will cause that retina to adhere to the underlying tissue. So basically you are creating a scar that will hopefully will plug that hole. We have a couple of other procedures pictured here. One that I would like to mention would be pneumatic retinopexy. So here the doctor has visualized an uncomplicated retinal detachment, and when they find the tear, they put a gas bubble, and that bubble of gas is it expands over a few days and it seals that retinal tear. So with those patients, it's important that they don't do a lot of eye movement post-procedure. So they should not read, they shouldn't watch TV, and they should follow doctor's orders. Assessment for retinal detachment. So the patient may report a sudden or gradual increase in the number of floaters, or they will experience those light flashes or the appearance of that curtain over the field of vision like we saw on the previous slide. An eye assessment for eye assessment changes will be done by a provider with the use of an ophthalmoscope to look inside the eye at the retina. This picture here is an example of retina detachment. And diagnostic results, again, will be based on that provider's exam of using the ophthalmoscope. And a dye can also be used to show the exact location of the detachment. So interventions. So we can assist with the examination. We want to encourage the patient to rest and stay calm while they're waiting to be seen by the doctor. So if a patient is telling you these signs and symptoms and it sounds like retinal detachment, they should be resting, calming, and not doing any activities until they're seen. We can loosely cover both eyes for protection. This can, because movement of either eye can make the internal eye injury worse. So we just want them to maybe close their eyes, cover their eyes, whatever they need to do. If the patient has a procedure, so positioning post-operatively is also really important. They just need to follow the directions that the surgeon or the eye doctor gives them. Depending on what type of procedure they have, they may have specific positioning for that. For example, after that pneumatic retinopexy that we just talked about, the patient should keep their head upright or sideways for a few days post-op because we don't want that little gas bubble to move. So that's just one example. Again, each one has its own instructions, which the patient should follow. Patient should also take stool softeners, increase the fluid intake and fiber because we don't want a patient straining because that will lead to an increase in intraocular pressure, which can cause that retinal detachment to get worse, or it'll interfere with the healing process post-operatively. And then pre-operative instructions are just important as post-operative instructions. So you want to make sure that they have, somebody to help at home, and if they have somebody they live with, then they should be given instructions also. And then as far as evaluation, we want the patient to follow up to make sure that everything is healing appropriately. And our last topic here is eye trauma. So these are categorized into two groups, blunt trauma and penetrating trauma. So blunt is on the left and penetrating is on the right. So this can happen to anybody. It can happen to kids, adults, the elderly, and it's usually preventable. So this is something we want to, encourage people to take care of their eyes to prevent these types of eye injuries. Risk factors for eye trauma include the male gender, participation in sports, certain occupations, if you're between the ages of 18 to 45, and if you consume alcohol. So those are all pretty self-explanatory why they're risk factors for eye trauma. So the assessments that we're going to go off of, vital signs. So if a patient is in pain, it can affect their heart rate, blood pressure, and respiration. Physical changes, we're actually going to assess the external structures of the eye. Is there bleeding? Is there redness? Is there edema? And then age-related considerations, not much going on here. Again, if you're age 18 through 45, you're at higher risk of having some type of eye trauma. So now we're going to go to our interventions. So if a patient has a penetrating object, we are not going to remove it. Instead, we want to minimize movement of the eye so we can cover the eyes and just have them kind of relax until, a specialist can come and remove the object. We want to provide comfort measures, so they're probably going to be in pain, so we should give them pain medication. Positioning may be, it just depends on the type of injury, but usually eye injuries may require the head of the bed to be like at 30 to 45 degrees so it can decrease the patient's intraocular pressure. We want to maintain a calm, quiet environment, minimizing that environmental stimuli, and that will promote rest, and it'll also minimize the eye movement so that doesn't exacerbate the injury. And then collaborative care. So we want to get an eye specialist on board for any type of traumatic injury to the eye because we want, to preserve eye function. And we do want to flush the eye. So if a patient has a penetrating object, We do want to flush the eye with some type of sterile solution just to make sure there's no other loose debris in there. And then if there is some type of chemical splash, chemical burn to the eye, we also want to flush it out to make sure that that chemical, we can get as much of that chemical off of tissue. You see in this picture is a Morgan lens. It is this little device here that's hooked up to irrigation, and it just continuously provides irrigation to the eye. So you'll see that in the emergency room. And this is our last slide of this module. This table is from your textbook, and it describes the types of eye trauma. It's straight and to the point. I recommend you read it. It shows the type of eye trauma and the treatments. And that concludes the eye disorders in this module.